be accurate depending on what we're looking for. So we do know for sure that there are certain types of genetics, BRCA1, BRCA2, that are found in patients who have a significant family history of developing breast cancers and ovarian cancers. And with those patients, you probably, either read about or heard, they get the prophylactic bilateral mastectomies, so because they're more prone to developing breast cancer and more prone to the family members developing breast cancers. But we're also looking at other genetic profiles. And now the accuracy of those, I'm not too sure of. I mean, we are starting to see these variations. And again, with all cancers, that's pretty much what they do. They kind of change their DNA. So you're going to see some mutations or some forms of cancers that are not like normal cells. And some of these variants are being looked at. And it kind of determines also why patients do get certain types of treatments, whether, again, systemic therapy types of treatments. Based on that, we have something called an oncotype, where we look at the cancer and look at its genetic profile. And then those patients are put at a risk, either low risk, intermediate risk, or high risk, to determine if they're going to need chemotherapy or not. And again, these are just factors that we're looking into. And again, with cancers, because we're looking more at DNA profiling it, we're starting to see more genetics involved in how we treat patients. And so going back to genetics and family history is very important. I mean, we all know that's kind of what determines these cancers. What's important is still being figured out or being assessed. Like, you can have all these tests done and you see them, but we actually have to look back, and it takes years of treatment. It takes years of following patients to kind of look at and see which patients were, had a more aggressive variant versus other patients. But we do know that there are some that are more aggressive than others.
I'm being asked on that is that when you're looking at a genetic test, as Dr. Ray said, typically you're looking at BRCA, but there are other genetic testing that is done, such as Lynch syndrome, Cowden's. So usually when a lady who goes in and has a genetic test, they will get a result that says positive, negative, or uncertain. And so when a lady comes and said, what does uncertain mean? And I said, there's probably something genetic going on, but we might not have discovered that gene yet. So 30 years ago, we did not discuss BRCA. 30 years ago, we knew that there would be possibly a group of women that said, my grandmother had cancer, my mother had cancer, my aunt has cancer, but the BRCA gene wasn't evaluated that way. And in one of the landmark decisions that our Supreme Court and our judges did, once someone discovered it, someone said, now we want a trademark and we want to hold to that. Mm-hmm. And then there was a decision that said, no, you cannot trademark genetic testing and genes that way. So just because a woman says my BRCA test is negative, and you look at her family history and it says aunt, cousin, every female, that doesn't mean that there's not a genetic correlation. That means that our research has not caught up to that gene yet. So if you come across that and you know that every female in your family has that predisposition, but BRCA is negative, that doesn't mean if you have a daughter, you want to look back and say, and this is a question I always go back, if you have your mother diagnosed and an aunt diagnosed at 50, at 40, you need to be diligent. You need to be 10 years back. If it's 40, it was seen at 30, you want to look at that. So you really want to start with breast health 10 years before that. Mm-hmm. Mm-hmm. Because that 10 years is that evaluation that can occur quicker and at a more expedient level.